Good afternoon. My name is Ingrid Lizarraga, and I'm a clinical associate professor of surgery at the University of Iowa Hospitals and Clinics. And today I will be talking about challenges and opportunities in rural cancer care. Thank you to the Academies for the opportunity to present. I have no disclosures. Data from the CDC consistently shows that mortality from cancer is more likely for the 60 million people who live in rural communities, even though many cancers have a lower incidence in these areas. There are many reasons for this, including poorer baseline health in this population, less access to screening, and less access to quality health care. However, if we examine survival outcomes for rural and urban patients who are treated in clinical trials, it actually doesn't differ by residence, which suggests that perhaps standardizing evidence-based care could mitigate some of the disparities that are associated with geography. So one appealing approach to addressing the disparity in access to cancer care is to expand and optimize the cancer treatment that's already being given in hospitals in rural communities, especially for more common cancers like breast, colon, lung, and prostate. One strategy that's proposed for this is quality accreditation for rural centers that regularly treat cancer patients. And accreditation has been used for a long time as a way of standardizing the quality care. And we see it, for example, in burn treatment, bariatric centers, trauma, for example. The oldest and most comprehensive cancer accreditation program in the country is the Commission on Cancer, or COC as it's called for short. And COC accredited hospitals have to demonstrate compliance for a number of evidence-based standards that address things like program structure, processes, and outcomes. There are currently over 1,500 COC accredited cancer programs in the United States, which make up about a quarter of all US hospitals. And these hospitals already treat over 70% of all cancer patients in the US. And there is evidence showing that COC accreditation does improve quality of cancer care for specific cancers. However, although nationally, most cancer patients are treated at COC hospitals, it's a completely different story when you break it down by geography. So these maps show the US shaded by rurality. So the darkest areas are the most urban or metro areas, and the lightest areas are the most rural. The map on the left shows hospitals, both COC and non-COC. So the yellow stars are COC hospitals, and the black dots and triangles are non-COC hospitals. And you can see them distributed across the US, although more on the coasts. In the map on the right, all of the urban and metro COC hospitals have been taken out. And you can see how few rural non-metro COC hospitals there are. In fact, some states don't have any at all. So why is this? Well, any kind of accreditation is quite resource intensive, and even larger, higher volume rural hospitals face both financial and workforce constraints that can make pursuing accreditation quite prohibitive. So although it's a potentially appealing solution to the disparity in care, it certainly doesn't seem to be happening on its own. One state that has had some success in the area of cancer accreditation for rural hospitals is Kentucky. In 2006, the University of Kentucky Markey Cancer Center started building a collaborative network called MCCAN, or Markey Cancer Center Affiliate Network, with hospitals across Kentucky, many of which were in underserved rural areas, with the idea of improving its referral base and improving cancer care. And in order to accomplish this, they developed programs and resources that were tailored to the needs of its members. It encouraged the members to refer complex cases to UK and then send them back for adjuvant treatment. And it allowed the members to co-brand with the UK logo. Because of this, in order to standardize care and improve quality across its affiliates, it required that all of the affiliate members become COC accredited, and it provided resources to help them gain and keep accreditation. So they recently looked at the results of their activities, and what they were able to demonstrate was that over the 13 hospitals that had been with them for 3 years, 12 of them had successfully achieved accreditation. Moreover, when they looked at performance on specific measures of treatment quality for particular cancers, for example, did the patient get radiation in a timely fashion for their breast cancer, what they found was that the performance of the MCCAN hospitals improved over the 3-year period, and also if they compared them to matched non-MCCAN hospitals that were similar in size and characteristics, that the performance of the MCCAN hospitals was better than the performance of the non-MCCAN hospitals. So these findings were really interesting because what they showed was that not only can participation in the network and becoming accredited objectively improve measures of quality, but also that it is possible for a network like this to support accreditation for smaller community hospitals. So we were particularly interested in this in Iowa because we are also a rural state and we have very few COC hospitals, and a lot of our patients are treated at rural hospitals. Our question was, can we adopt the MCCAN model for rural states, other rural states? MCCAN works great for Kentucky, but there are some things that might not be translatable. For example, there is a financial relationship in this network. There's the branding issue, which may not be appealing or feasible in other places. And so would it be possible to extract what makes MCCAN successful with respect to supporting accreditation and improving quality and adapt it to other places? And so earlier this year, we actually received NIH funding to do exactly that. The objectives of our grants are to study MCCAN and identify what the core functions are. That is, what makes MCCAN successful with regards to accreditation and quality, and determining which activities and strategies MCCAN uses that can be adapted and customized to Iowa hospitals. We will then apply these adaptations to the 4 largest rural hospitals in Iowa, which are pictured here in the map of Iowa with the 4 red crosses. And these hospitals have agreed to partner with us in creating a collaborative network in which we will determine the barriers and facilitators to accreditation using these MCCAN strategies. And then finally, we will measure objective outcomes to see whether our intervention is actually able to impact quality of cancer care in Iowa. So far, we focused our efforts on interviews with the MCCAN hospitals and team members to try and identify these core functions. This work is ongoing, but here are some of the key themes. There's the importance of tailoring the accreditation activities and standards to the goals of the individual hospitals in order to increase engagement and buy-in. A key feature is access to resources of the Marquis Cancer Center, which is an NCI designated cancer center, including peer-to-peer support for physicians and other clinicians, education, again, not just for doctors, patient navigation, quality improvement, best practices, services, and access to things like clinical trials, things that these smaller community hospitals would not be able to do on their own. Also important was the mentoring of physician champions at these hospitals, supporting them, and then the importance of shared trust. Anytime you have a relationship between a larger cancer center and smaller community hospitals, they have to believe that the patients they send are going to be sent back for care. And so in conclusion, although our work is far from done, we believe that opportunity exists to impact rural cancer control locally by improving the quality of cancer care given in rural hospitals. We believe that quality accreditation can impact treatment outcomes, but that there are inherent challenges, and that a collaborative model has the potential to increase community hospital engagement and grow the diversity of ideas to address this issue. But that ultimately the success depends on leveraging the resources of NCI designated cancer centers, of which there are many across the US, that can potentially impact other states. And finally, I'd like to thank my team, Dr. Mary Charlton, who is the PI and the director of the Iowa Cancer Registry, the Marquis Cancer Center affiliate team who've been great partners in this, the hospitals that have agreed to participate, and then the ICANN research staff. Thank you.